you know why I'm feeling that? I'm feeling that like I'm especially from the point of the nurse view, because it is so hard to go and see that old 90 years old man in a hallway cannot walk and have a depression. You know, I'm looking from the point of the Canadian nurse in a hospital.
Thank you for that. Thank you for sharing. As hard as it is to listen to you say that. So what's the population of Iran? What's the population of Iran? How many people in Iran?
I don't know exactly.
70 million. That's a big country. Okay. All right, Netherlands. Oh yeah, we can see that the Dutch GPs are more advanced, quite a bit more advanced than the European average, including some more advanced prescribing usage and lab results, which they receive electronically. However, that's another country that's stalled. Big announcement in January 2009, they were going to have a national EHR. Sorry, they announced that at the end of 2008. Within 3 months, they said they were going to postpone it. Huge hue and cry about security and confidentiality, and apparently the GPs were quite effective in convincing the patients that they should opt out. And apparently the GPs and the government do not get along very well because the government mandated quite a radical health reform to the way in which healthcare was going to be covered in terms of insurance and whatnot in 2006. And they're quite an effect on the GPs. And so there's a lot of animosity between them. So too many people were opting out, and in January they said they were postponing it. By October they had come to an agreement, a compromise. Basically the compromise is that they will in effect sort of facilitate the development of local systems and regional systems, and someday perhaps connect them to a national system. So we're now going back and starting to do some work, but in a quite different way in which they intend to do it. So it's another country that has some struggles. Spain, not all of Spain, but just one part of Spain, Andalusia. Did we talk about this last year? It was the year of the election. They have, this is another nice part of Spain. You've been there. It's, Sevilla is the center of it in there. Their public health service was quite dramatically reorganized, I guess, about 10, 15 years ago. And the biggest reorganization was that they created, like out of nowhere, created 1,500 health centers, which they didn't have. And they instructed, that's probably the wrong word, they said to all the physicians, to GPs, all the GPs, thou shalt move into one of these health centers. And they told them which one it was. Unlike the New Zealanders, which let the GPs organize themselves, the Spanish said, no, we're going to go into working. And I think the minimum number of GPs in the health center is 10. 10 to 15, at least in the urban areas. They reduced the number of their hospitals and concentrated all their energies on 37 hospitals through this region or province. Again, fairly big.
Dennis, can I ask you about the hospitals with regards to the Manitoba strategy, where they have the acute tertiary facilities with specialized academic, and then more the medical, so urgent to chronic to. Is that somewhat of a similar structure?
The only part that I can comment is the acute side. Okay, the long-term rehabilitation, those aspects. My sense is, well, not sense, I know. Every one of those 37 hospitals is a full emergency department. Okay? So they shut down, I think, a lot of the community hospitals and concentrate all their energies on these, what they call regional hospitals. They use the different words instead of we use region, province, and region. They use region and province. They concentrate all their efforts on that. So they're all sort of full-flow tertiary hospitals, from what I can tell, scattered around this quite large geographic area that there was there. At the same time, they set about to create a single health record for every citizen, an electronic health record. And in their case, they decided single means single. So they started in primary care. They had very, very few systems in primary care at the time. This goes back into the 90s, mid to late 90s. They had very little technology anywhere. And if there was any, it was in the hospitals. So they started in primary care. So in 2002, this was a situation in terms of the number of people being able to be covered by this new single record, okay? By 5 years later, they basically had 79% of the region covered. Now what that means is that the patient is assigned, a patient, I think they're free to select whatever primary health center they want. Obviously, most of them are geographically, they pick the one closest to them. And once they're in the center, then they're assigned a primary care physician. But the model is such that, for whatever reason, the primary care physician is not there at the time they're going to be seen, they obviously get seen by another one, because there's multiple primary care physicians. And those centers are open quite long hours, so it's not quite the same model here in Canada. They still open quite well. And I think they also, if I'm not mistaken, I have to check, they also cover out of office hours. So it's basically a 24/7 operation. They're now, they told me they're now up to sort of 94% of the population. And the only part that's not covered yet are the rural areas that don't have the broadband coverage. And we're waiting for the government to put in the broadband network into those parts of the more remote areas. So the patient is seen by the GPs. They access the record, they update the record, and that record is available to anyone in the region. Anyone in the region in primary care, so any of the 1,500 healthcare centers, any of the 37 emergency departments of the 37 hospitals, and any of the outpatient clinics attached to those 37 hospitals. So that when a patient goes to an emergency department, is treated, something happens, the record's updated, and the patient goes back to see their primary care physician the next day, everything's there. As long as it's from emergency or ambulatory clinic. Okay. They're now in the process of building in the capability to share that record and update that record from all the acute care units in all 37 hospitals. I think they're hoping to do that over the next 3 years. They're just about ready to announce that they finished their first acute care hospital in terms of all the acute care units having access to sharing and updating that way. So their intent is to have one record, one patient for an entire healthcare system. They're well on their way. And they've moved very quickly relative to a lot of other nations. Yeah.
So what's stopping Canada from doing something like this?
Emotion and politics?
Remember, I'll give you the answer a little bit later. It's one word. Okay, Norway. Again, quite a little more advanced. The Norwegian physicians are GPs are very automated. Many of them, most of them running paperless offices. They scan the data coming in from specialists that are not automated. They scan it and put it in the records electronically. They've got quite an extensive dissemination of EPRs in their hospitals. From what we understand, they're probably as advanced as any country in the world for the hospital side of things, in terms of the degree of which automation has occurred inside of hospitals with EPR. They've had standardized messaging for quite a while, and the thing that's not as is they're not as interconnected as other countries, particularly such as Denmark. But other than that, they're well up there. They would definitely be in the top third. they're having problems integrating across hospitals and with GPs. They really don't have a good national network yet, which is also holding them back. Sweden, beautiful Stockholm. Sweden is, again, high usage by GPs, very high usage. And probably second only to Denmark in terms of the use of e-prescribing. Okay, in the sense that the physician completes the prescription in a computer system and sends it electronically to a pharmacy. Now, I think Sweden chose the approach right off the bat, and I gather Denmark is modifying their approach to this model. But they send the prescription to a mailbox. And when the patient arrives in the pharmacy, says, I have a prescription, then once they've uniquely identified the patient, they extract the prescription out of the mailbox. The Danish approach was to send the actual prescription to the actual pharmacy. And it was based on when they sat there with the patient and saying, okay, which pharmacy do you want to go to? They select the pharmacy from the pull-down list and file. But I think the Danes are switching to a mailbox too.
Can I just ask you a simple question of that graph that you've got up there? This is a weakness of mine.
Yeah.
The area that you're showing covered, there's a percentage of GPs that are using e-prescription. Is that what the dark area
Yeah,
means?
dark blue shows that, whatever that number is, 75 or even 5%.
Okay, so it's just that the area would be represented.
Yeah,
So
and
if you
you
don't
can
see
see-
anything there, it means that no one's doing it, or they're not doing very much of it.
Yeah. Well, no, what you can't see with this, unfortunately, is you can't see behind the light blue as to what the real picture is in parts of the situation in Sweden.
Oh, okay.
So what's most significant with this type of graph and this type of approach is to show you what's different. It's particularly different from the norm or average. So you can see that from the point of view of e-prescribing, Swedes are way ahead of the European average. That's basically because of all of Europe, there's only 3 countries really doing any kind of e-prescribing. Now, in this definition, this way, it means it's really e-transmission of prescriptions. That's what that really means, okay? Because most of them are using e-prescribing from the point of view of at least printing a label, printing a script. This is more the transmission of the prescription electronically to the pharmacy. So Sweden's way up there. Netherlands was up there a bit. So most of the other ones haven't started.
So when that transcription is transmitted, it's just the unique identifier, like the patient's name and whatnot?
The whole transmission, the whole script.
The whole script, patient name,
The
everything?
drug, the dosage, the route, yeah. And some of the countries are, the prescribing capability, like in Denmark, especially in Sweden to a certain extent too, when the physician picks which medication, the thing that comes up first is the generics that the government is. They can go beyond that and go to non-generics if they want, but there's incentives in place to use the generics from the formulary. And in Sweden too, the other aspect that makes it a little easier for them to make all this happen is all the pharmacies belong to one company. And I think the last I heard that they're going to have to change that. The EU is giving them a lot of flack. They don't like that idea. They want competition and more freedom. So right now, they all belong to one company.
So after the prescription is filled, something happened to the record in the mailbox then?
That varies. That varies. In most cases, nothing else happens. Denmark, however, does. The pharmacy then sends a electronic note to the physician saying that the medication has been not prescribed, it's been dispensed. The medication's been dispensed. Okay? So now all they really know is that the patient now has the drugs in their hand. They have no idea whether the patient takes the drugs.
So what's to stop the patient from going from one pharmacy to the next?
Well, because they're all to the same system. They're all to the same system. I mean, when the pharmacy opens up and looks at the medication profile, okay, they can see what medication that patient's already on. Just like the pharmacy here. Okay, so we went to the BC pharmacy here, and with that handwritten prescription, if that handwritten